you have logged in. Welcome to the IAGS International Webinar. This is a series of international webinars we have been conducting during the COVID times after we were done with the initial general information for surgeons to look after COVID patients. And today's webinar is on an important topic on sleeve gastrectomy. So we have seen how sleeve gastrectomy has grown over years. And there was a time when about 3 years back, I was doing almost 90% sleeve gastrectomies, and worldwide they were almost 60% plus. And we were seeing a situation where people were thinking that sleeve gastrectomy might dislodge Roux-en-Y gastric bypass as the gold standard procedure. But somewhere around 2011-12, early reports started coming in about reflux-related problems of sleeve gastrectomy. And as more and more people started reporting them, I think the awareness settled down that sleeve is a refluxogenic procedure, and people started being cautious about selection of patients. And then there has been some discussion on the weight regain potential of sleeve versus other bariatric procedure. And then in last 7-8 years, the MGB or OAGB, as we know it now, is becoming more popular in countries like India and many other countries. And so I think this is the right time to discuss how close or how far sleeve is from being the gold standard. And if it is not there, what are the roadblocks? And we have Praveen, can you share the screen, please? And we have a phenomenal panel today. We are honored to have some of the people who have done the major work on sleeve gastrectomy. I'm joined with my moderator, co-moderator, Dr. Praveen Raj, who is at GEM Hospital, Coimbatore, and all of you know him. And Professor Michel Guénier, who pioneered sleeve and who was very bullish about sleeve in the initial years. We'll come to know his approach now, and who conducted multiple sleeve gastrectomy consensus summits. And we have all gone through those in detail, and we know how things have changed over here. Dr. Abdul Rahman Nemeri, who is now in US and has published extensively and has his views on various bariatric procedure. CK, as most of us call him, CK Wong from Taiwan, who is as big a name in this part of the world as any other senior surgeon. Dr. Mohit Bhandari from Indore, who has also extensively published and is doing very large volume of bariatric surgery, probably the largest in India and many other countries. Dr. David Kerrigan, who is the president of British Society of Bariatric Surgeons, BOMS, and of course our own Deep Goyal, who is in Delhi and doing very good volume of bariatric work and is helping the association with a lot of these webinars. And so we have a full house. And can you go to the next slide, please? And what we have done today is that we are going to put a case mix of each of the panelists. This is to give you an idea of the preference of the surgeon in his clinical practice. And as it goes on to show that now I am doing almost 60% Roux-en-Y gastric bypass as primary procedure, and the sleeve is only about 39%. MGB is extremely rare, and this is mostly for patients who are coming in from and asking for this procedure, high protein consuming patients. Otherwise, in primary procedures, surgeries, I don't do it. But in revisional surgeries, my preference, these are revisional surgeries from conversion of sleeve to other procedures. So we are only talking of sleeve today, sleeve conversion to MGB and sleeve conversion to RYGB. So I prefer MGB there, primarily for ease of operation in weight regain patients. In refluxing patients, where the primary cause of doing it is reflux, or there is a clinical reflux on preoperative assessment, I still prefer a Roux-en-Y gastric bypass, whatever the technical problems are. So this is my case mix. And Praveen, would you explain your case mix and then you take over?
So, good evening, ladies and gentlemen. And I think it's a great privilege and pleasure to be having some great panelists and to co-moderate with Dr. Raman Goel, the president of IAGS. And hope we will make sure as much as possible to make sure you have on this discussion on sleeve gastrectomy. So I think more like a disclosure. So this is a case mix so that it obviously gives us whether are we biased on one side or not. Of course, this is primarily going to be sleeve gastrectomy. We will try our best not to move on to the other sides, not to so as to prevent any controversies. But just to be on the sleeve side, my majority of work is sleeve gastrectomy, followed by Rowan Weiss and mini gastric bypass and some loop DJBs. Of course, when it comes to revision, I have a significant numbers of surgeries is what I do as my primary procedure whenever the sleeve has failed, especially when restriction has failed, when sleeve hasn't dilated much. I try to give in a malabsorptive component. So this is my case mix with regard to primary and revisional bariatric procedures. And as we go on with the discussion, depending on the panelist who will be talking, we will be showing up the case mix of each of the panelists also, just to give you an understanding what kind of practice that they have at their geographical location, so that would give you an understanding of the way the discussion that they have based on their experience. So this was Dr. Raman Goel's idea, and I've definitely loved it to have it. So I think it's time to move on for the panel discussion. So first question to Dr. Nimeri. I think you're already connected. Of course, it's very difficult to define gold standard in general science by itself. It is always very difficult, especially in bariatric surgery when there has been a big evolution of procedures over time and again and time and again. And whenever we have multiple procedures, it's always not possible to have. But then still, we all, including this panel, where we are trying to talk on sleeve gastrectomy as a gold standard, because we are trying to search to find the standardization. Can we make it as simple as possible is what all of us around the world have been hunting to do. So what do you think? That can we really have a gold standard bariatric procedure? Or if we need to have, what is that we need? Over to you, Dr. Nimeri.
Good morning, Raj. Can you hear me?
Yes, please.
Thank you again, and I want to thank the Indian Association of Gastrointestinal Endosurgeons for the kind invitation. I think it's very difficult to say that there is a gold standard procedure. Every patient will probably have a procedure that's best for them. I can tell you the way we look at procedure selection. So let's start with sleeve gastrectomy, which is the topic of discussion today. So I use sleeve gastrectomy for 4 types of patients. A low-risk patient who their main idea is meaning the BMI around 40, no previous medical problems, no reflux. For that patient, I think sleeve gastrectomy is a good operation. Also, a high-risk patient, someone who has multiple medical problems and minimizing the risk around the time of the surgery is reasonable. We use it for patients with inflammatory bowel disease, especially if someone has Crohn's disease, and patients with multiple previous abdominal surgeries where the chance for having a lot of adhesions is a large possibility. So this is where we use sleeve gastrectomy. When it comes to gastric bypass, we use it for patients with a higher BMI, but a BMI that is less than 55, closer to maybe lower 50 range, diabetic patients, and particularly with reflux. And the larger the BMI, we lengthen the biliopancreatic limb with the same rule limb. And then finally, we use duodenal switch for patients when the BMI is over 55, or someone who has very severe diabetes. Their main concern is to get their diabetes controlled, but their risk overall is low, meaning they're young, they're a young patient. So there is no particularly a gold standard procedure. We use different procedures based on the patient that presents to us. And then finally, if someone has history of smoking, someone has history of kidney stones, these things also affect the decision making. So we try to have someone who had history of multiple kidney stones in the past undergo a sleeve if everything else is equal. Someone who is a smoker and has a chance to smoke again, not have a Roux-en-Y gastric bypass. And that's the way we look at it. We rarely use one anastomosis gastric bypass, and in patients where we need the benefit of the longer BPLM, we just use a longer BPLM Roux-en-Y gastric bypass or a DS.
What is your opinion about certain surgeons who believe they do primarily, they call themselves sleeve surgeons, they call themselves MGB surgeons, etc., who believe one procedure can take care of everything? So what do you think? Because they believe that's the gold standard. So what's your thoughts on that, Dr. Nemeri?
I think this becomes a disfavor to the patient. I mean, obviously, everybody knows their comfort level, and a surgeon should do what they're comfortable with. I get that. But at the end of the day, I think the best service for the patient is to have an informed consent. Informed consent means you get the different options laid down in front of you. And it's perfectly fine for a surgeon to tell a patient, listen, what you need is a DS. I do not do a DS. I'm going to send you to someone else. And we have to treat obesity very similar to how cancer is treated. Meaning, if someone is a high-risk cancer patient, we don't do the highest risk operation first. We try with neoadjuvant treatment to minimize their risk and lower it and see their response to that treatment before we contemplate any surgical intervention. So similarly, our patients come in different shapes and sizes. Their past medical history, their age, their BMI makes a very big difference in what we choose. And it's very difficult to choose one procedure for all the patients.
Yeah, I think I would certainly agree with Dr. Nemeri that we will not be able to fit one shirt to all the patients. That's exactly why all the case mix that we've been having, that there has been multiple colors that you see in the case mix of all the surgeons that you will see, because one shirt cannot fit in all. And I think the same thing, the IFSO 2019 World Health Registry also tells us that at the different geographical locations, the Roux-en-Ys and the OAGBs and sleeve gastrectomies have had their presence for different set of people. And of course, we need to consider the ethnic variabilities. We need to consider the clinical comorbidities. Various things needs to be concerned. But looking at all that, in spite of all that, sleeve gastrectomy continues to be the most popular bariatric surgery across the world, starting across all the chapters of the IFSO, and not just the chapters of IFSO, but also this was a study from India, where we looked at the trends and progress of bariatric surgery in India. Although we've been growing in numbers over the years, still sleeve gastrectomy continues to be the most popular bariatric surgery in India. And however, every single procedure has a point to stay, and no procedure, I think, can take the leader of being the gold standard. And I think suiting the right procedure to the right patient will be the right bariatric procedure. With that intent, I would move on to the next question to Dr. Kerrigan, because suiting the right procedure to the right patient would be the ideal bariatric procedure. But how would you choose it? What would make an ideal bariatric surgery for you? So what are the factors that you would look into it to choose the right procedure for your right patient?
Okay, well, namaste. If you show me an ideal patient, I'll show you an ideal bariatric surgical operation. I think it's very difficult to find both, but I've split this answer really up into 10 points. And I think the ideal procedure should be safe. And I think if we were going to go for the safest operation, we'd go for the gastric band, and that's what we'd all be doing, which none of us seem to be. The sleeve and the gastric bypass seem to have fairly similar safety, but we need to think about long-term safety as well as just the perioperative mortality. And then when you look at gastric bands with a reasonably high risk of reoperation, of slippage, of erosion, maybe it's not such a safe procedure long-term. I think the second thing we want in an ideal operation is we want to have a low risk of serious complications. And I think the bypass maybe doesn't do quite so well there. We have this issue we were discussing before the meeting started about refractory ulceration, strictures, fistulae, perforation, and that can be an issue with gastric bypass. Also, we have this really difficult problem some patients get with reactive hypoglycemia and dumping, which can really be challenging to treat at times. So maybe a sleeve looks pretty good from that side of things. I think a third thing is that the operation has to be effective. I think the bypass is, a little bit better in terms of weight loss than a sleeve. But if you were somebody with 80 kilos of excess weight, the difference between the two operations on average probably going to be something like 7 kilos. It's not a massive difference. And of course, in the super obese patients, bypass doesn't tend to be as effective. The results aren't quite so striking as they are in patients with lower BMIs. I mean, a fourth thing, I think for the ideal op, it's got to improve the metabolic syndrome. And if we look at the 5-year data from the Stampede trial, again, sleeve and bypass compare very favorably with each other. A fifth point is the ideal operation should get all these great weight loss and improvements in metabolic syndrome without causing malnutrition. So if we wanted the operation with the best weight loss, the DS or SADIS will probably be the ideal procedure, but that comes at a potential cost for those patients. They are challenging patients at times to look after and keep well after surgery. Number 6 on my list of 10 is the ideal op should be a durable operation. It should keep weight loss, a durable long-term weight loss should be the outcome. And again, there is data out there to show both sleeve and bypass, do produce durable weight loss. Number 7 is it's going to be an operation that most surgeons can do well. And again, the sleeve is an easy operation to do. And it's one that, although it's also an easy operation to do badly, generally speaking, it is something most surgeons can manage. The problem with the DS and the SADIS getting widespread adoption is a lot of surgeons would find that technically quite challenging. I think an 8th point is that the ideal op should be reproducible and standardized. And again, I think a sleeve seems to score quite highly in that regard. There's a lot of variation in limb lengths for gastric bypass, length of the gastric pouch, whether it should be short to reduce the risk of ulceration or longer because it's easier to revise. So, but a sleeve is a pretty standardized procedure. I think number 9, the operation that's ideal should be easy to revise, and it shouldn't compromise future surgery because obesity is a chronic relapsing disease. And again, you could make an argument for sleeves, potentially bypasses can be quite tricky to revise. And the last one really is it should be acceptable to patients. And the gastric band in that regard has fallen off its perch of favorability with patients. Patients like the idea of a sleeve gastrectomy. They feel more comfortable with it than a gastric bypass, which they see as more radical and perhaps a little bit more dangerous, although actually that's not supported by the evidence. So I've just kind of made a great argument for the sleeve gastrectomy, and yet when you look at my case mix, actually that's not the most common operation that I do. The most common operation I do is at the moment an OAGB. And I think that's because, in my view, OAGB has changed the landscape for gastric bypass. I think a Roux-en-Y, in certainly the UK experience and our units, does carry a significant risk of stomal ulceration. You're anastomosing unprotected small bowel directly onto an acid-producing gastric pouch. And if you want to make that gastric bypass easier to revise, because we know many patients will need revision at some point, you make a longer pouch. And that longer pouch increases the risk of stomal ulceration, which in my view is the Achilles heel of a gastric bypass. The one anastomosis bypass has changed things for us because it is so much easier to revise. I think that is the main advantage. There's some evidence it produces slightly better weight loss, slightly better diabetes remission, but the real advantage is it's a lot easier to revise if a patient should need that. And certainly in the UK experience, the incidence of stomal ulceration is less, perhaps because of bile neutralizing the acid leaving the stomach. We're looking at about a 1 to 2% incidence of symptomatic stomal ulceration. So I think the sleeve would have been a great choice based on my 10 criteria if it wasn't for the one anastomosis gastric bypass.
That was,
Dhanyavad.
I think that is being called hitting the ball out of the park. I think you just knocked the whole question, and I think you just made everything, I think, too complicated a discussion quite simple. Yes, but I think it's certainly only when we get the ideal patient, we'll be able to choose the ideal operation. An ideal operation is something that can give the best possible results with the best possible outcomes, and no surgery can be 100% with 0% complications. So this was a small anecdote from one of the discussion, a heated discussion in obesity surgery some time back with regard to an MGB, where there was a discussion on the long-term results of MGB when the authors have replied saying there cannot be one bariatric procedure and each has its own advantages and disadvantages, and how sleeve has its own place in in the bariatric surgical practice. Bypass, Roux-en-Y, although standing the test of time for so long, has its own issues with regard to post-operative hernias, marginal ulcers, and weight gain, as I just mentioned. And OAGP is emerging to be a very good procedure. And I think there can be no one procedure that can be called the gold standard or that can be called the ideal bariatric procedure. We certainly agree with both of you. And we have this couple of questions just to spice up the beginning of it, because before we get to the actual sleeve gastrectomy part, we just want the audience to just get connected with us before we actually get too much into the sleeve aspect of it. And I think I thank Dr. Nimere and Dr. Kerrigan for your wonderful thoughts on these two. Over to you, Raman Goel, for taking it on.
So, Michelle, since you're the surgeon who has been there for the maximum time in bariatric practice out of all those in the panel, Praveen, can you have the next slide, please? So, what is your take? You know, so many procedures have come and gone, right from jejunal bypass, BPD, and then VBGs, bands. You started sleeve worldwide. What is your learning, or what do you see the future of sleeve in times to come with all the reservations that people have worldwide?
Well, Dr. Goel and Dr. Rash, thank you very much for the invitation to participate on behalf of the Indian Association of Gastrointestinal Endosurgeons. As you know, I've been coming to India very early in the development of bariatric surgery, even did some first in your country regarding this laparoscopically, and I think it created a big spark about those surgeries for obesity and type 2 diabetes. So this week I'm on vacation, and sometime I put books in my suitcase. And I had ordered the book of Henry Buchwald, the last book of Henry Buchwald, which was his portion related with Owen Wagenstein. Owen Wagenstein is a surgeon that passed away many times, but never got the Nobel Prize for the use of the nasogastric tube for bowel obstruction, which benefited hundreds of millions of patients worldwide. Henry Buchwald came to the University of Minnesota and interacted with some members of the faculty at the time. And one of them was Richard Varco. Richard Varco is now credited to have done the first bariatric surgery in the world. Richard Varco was the one who did the first jejunal bypass. And I'm very fond of reading all those initial papers, the Scopinaro papers, the Richard Varco papers, the Ed Mason papers, and so forth, because you learn a lot about the development of bariatric surgery and those procedures. And the jejunal bypass was interesting because it had an intact stomach and duodenum, and then you use the last 18 inches, if you want, 45 centimeters of the GI tract, and excluded a long portion of the small bowel. But this was a hint that this procedure was able to produce the most dramatic effect on type 2 diabetes, in spite of having an intact stomach and duodenum. So that's putting aside everybody who believed that duodenal exclusion is important. And so it's important as a surgeon to read a lot of those new findings. But, I started to do laparoscopic Roux-en-Y gastric bypass in 1995 when I arrived at the Cleveland Clinic. So my slides about what I'm doing now is also important of what I've been doing in the last 25 years. If I have an experience of 25 years of laparoscopic Roux-en-Y gastric bypass, and I tell you that now I do them less than 10%, it's significant because I've seen patients fail over the years, as opposed to a young surgeon who starts to do Roux-en-Y gastric bypass, doesn't know what happens 10, 15 years later in his patients. If they're regaining a weight or they're failing in 40% of cases, it's important to know. And so the same with duodenal switch. I have 21 years experience in laparoscopic duodenal switch. Sleeve is 20 years experience. And if you combine all of this together, I believe that the sleeve is an important contribution, because people are comparing their operation with the sleeve. but it's a wrong comparison because sleeve is a spectrum of procedures. It's a continuum of different stages, 1 stage, 2 stage, and even 3 stage if you consider that you can go from sleeve to SADI and then SADI from duodenal switch, or the same from sleeve to mini bypass to Roux-en-Y gastric bypass. So I believe that it is wrongly compared in many randomized controlled trials because they're not comparing their operation with the stage or group of procedure concept. And so this is difficult in this discussion. So I've learned a lot and read a lot, and I encourage many surgeons to do so because they are very interesting concepts being vehiculated in those studies. I believe that the sleeve will continue. And there have been 3 scares in laparoscopic surgery. I started my practice, I was an open surgeon in 1988. And then laparoscopy started, and I changed and embraced this revolution. But I saw 3 scares in over 32 years of laparoscopy. The first one was metastasis at the port site. And some people were reporting this and then scaring everybody that you should never do laparoscopy in cancer. And it stopped the evolution of laparoscopy in cancer for 15, sometimes 20 years. The second scare was you should not do colon cancer by laparoscopy. And it took a long time with some large randomized control trial to break this myth. And the third myth I can tell you is the reflux story in sleeve gastrectomy. That's another one, and is again to scare all the surgeons that you should not be doing sleeve gastrectomy. And we will have more discussion today about this, but this is the third myth of laparoscopic surgery.
Yeah, great.
Can I make a point?
Yeah, sure, Deep. Please go ahead.
Yeah. So I think when we talk about the criteria of an ideal procedure, I think we must understand that the criteria for ideal procedure for any other procedure is different than bariatric surgery, because here the patient has so many variables attached to it, different sizes and shape, as one of the colleagues said in the past. So one must keep that in mind before saying what is gold standard. But here we have to see what is giving benefit to the patient on all fronts and still maintaining quality of life. So when we talk about sleeve, it is simple, it is reproducible, it is most physiological, it has lesser complications and good results on all fronts, reasonably good results on all fronts. So we need to, when we answer that question, we need to keep this in mind.
Okay, sure, Deep. We are going to discuss all these issues now, specific issues. Can you go to next slide, please, Praveen? So I think Michelle has wonderfully explained the evolution of bariatric and laparoscopy in general, and I don't need to go through all these details. We have discussed, seen, worked with the various pioneers. Next, please. And we started our career as VBG surgeons in India, and then till Michelle came, and I had the pleasure of assisting him for the first sleeve in this country in 2004 in Coimbatore. And so next slide, please. So Michelle, we continuing this, Deep has actually given a good platform to ask you the second question. We all know the reasons for popularity of sleeve. And you have also said that this is a scare about sleeve. So what I'm not going to ask you what is the reason for popularity of sleeve. Why sleeve is seeing difficult times now? Are those reasons valid?
Yeah, I think it's Praveen who showed the slides of the percentage of sleeve in different continents, and I think in North America it is wrongly quoted because the statistics from the ASMBS includes revision, which were about 15%. So it dwarfed all the other percentage. But if you look at primary procedures in the United States, 75% are sleeve gastrectomy. And that percentage increases in small percentage still year after year. Now Roux-en-Y gastric bypass, which was the gold standard, which now has been performed for 50 years, is at 17% in the United States. So why is it that all surgeons, including myself, who were doing 100% Roux-en-Y gastric bypass has changed to a sleeve gastrectomy, because the sleeve gastrectomy concept permits you to revise it to something else and accommodate to the patient. Because when you see a patient, you see a patient once, 2 times, or 3 times in your office, you don't really know this patient. You don't know if this patient is going to be compliant or not, or if this patient's going to take their minerals and vitamins, they're going to come back for blood work and etc. And it's scary, because if you do a procedure that has a final or long-term impact on nutrition and problems, and you don't know this patient, you might be doing a disservice to this patient. So the popularity of sleeve, I think it's because it's easier to do than Roux-en-Y gastric bypass technically. It's also shorter to do, so you can treat more patients in the time that you have. We all have limited time in a week. The other thing is there is less morbidity. There is less mortality. If we look at the number of the MBS-QIP in the United States, you see that the mortality of a Roux-en-Y gastric bypass is twice the mortality of a sleeve. Now, you see people changing from sleeve to Roux-en-Y to save some cancer of the esophagus. I want to see what are the numbers of cancer of the esophagus. But if you're going to save 1 or 2 cancer of the esophagus out of 100,000, you're going to kill 100 people by doing so, by doing a Roux-en-Y gastric bypass instead of a sleeve gastrectomy. And I think the popularity of this is that patients are scared of potential other problems. If you look in the Swedish study, over a period of 5 to 7 years, 25%, 1/4 of patients after Roux-en-Y gastric bypass gets reoperated with a major abdominal surgery. That can be bowel obstruction, that can be for ulcers that perforate or bleed, and that can also complicated biliary operation because you don't have access to the biliary tree. So you have 25% of reoperation. Another great study is by Korkulas from the University of Pittsburgh, who is a big proponent of Roux-en-Y gastric bypass. They review in their insurance number of patients and multiple patients, and they found out that the mortality of a Roux-en-Y gastric bypass over a 5-year to 7-year period is 50% higher than in sleeve gastrectomy. So how many patients are we going to save by switching operation is something that is important to look at. It's important to look at. Just because we think we're going to save some esophageal cancer and it's going to be dangerous, then we're going to switch operation, which has other implications of mortality and morbidity. So that's important. And I believe that the patients are choosing sleeve gastrectomy because they've heard so many stories with other operations. They want what's easier for them at the beginning. Now, what's wrong in putting someone on anti-acid medicine? You know, if you look at the United States, there are probably 100 million people on PPIs. So what's wrong of putting them on medication if they need to? It's interesting that the Swedish study from Karolinska shows that after Roux-en-Y gastric bypass, if you do this for reflux, 50% of the patients are back on PPI 5 years later. So you're going to do an operation because you think they have some reflux symptoms, change this to Roux-en-Y gastric bypass, but in half of the patient, you're going to be stuck to putting them on PPI, and you're going to be back to square one as if the patient had a sleeve. So I think that for all those reasons, I think sleeve will remain popular. People will realize the scare that was created by a few papers on sleeve gastrectomy, because the reality is something else. We should be looking at that paper in press in Sword right now, published by Aurora Pryor, who is the president or the past president of SAGES. This is on nearly 50,000 patients. They looked at the incidence of esophageal cancer in sleeve, in DS, in banding, and in Roux-en-Y gastric bypass from 1995. And looking at this cohort at the end, there is no difference in the incidence of esophageal cancer. So that is striking. These are more facts that are important to us to now look back at our decisions. And Musella has looked at the incidence of esophageal cancer over the last 8 years, the papers, and they found out that the incidence of esophageal cancer in Roux-en-Y gastric bypass was 8 times that of sleeve. So this is important. If we're going to do Roux-en-Y gastric bypass on all the patients who have symptoms, those are the patients who will develop esophageal cancer over time, I think. Those ones require a gastroscopic surveillance. And we're all there stating that patients who get sleeve should get a gastroscopic surveillance. I think everybody who gets bariatric surgery should get endoscopic surveillance, because we're going to find ulcers, we're going to find Barrett's in all of them. The incidence of Barrett's, GERD, and esophagitis increase in all bariatric operations over time. So let's not kid ourselves.
Yeah. Thank you, Michelle. That's wonderful. Since you are on a vacation and you did not have access to your data, we couldn't get your case mix. Can you just briefly give us an approximate idea of what is the percentage of sleeve in your practice now?
Yeah, as I said, my practice has changed over 25 years, and I started with 100% Roux-en-Y gastric bypass to slowly think that this operation should be reserved only on patients who have truly severe reflux or on PPI all the time. So that is less than 10% of my practice. My practice remains sleeve gastrectomy in about 85% of cases, and it has not changed since. I used to do a lot of duodenal switch, but now we're doing SADIs, and we're going to do SADIs mostly as a second stage procedure, not as a first stage procedure. I try to discourage patients to get a hypoabsorptive surgery as a first stage, unless they have a family history where this operation works very well. Otherwise, I try to get them in 2 stages.
Okay, thank you, Michelle. So I think we all are aware of this consensus conference called by Michelle, and which had shown that sleeve has certain advantages. So we move on to the next slide, please. And then we have these, the mid and long-term results, which have come from India. And this publication is from Dr. Sandeep Agrawal from Delhi, which shows that even after 5 to 7 years, though the number of patients at 5 years were small, it continues to show good diabetes remission in almost 84% patients, and substantial improvement. One thing that we have noticed, and which is different, can you go to the next slide, please? Is this is our own publication of 5-year follow-up data. We have found a much higher diabetes remission rates in India, maybe because the population is more cereal eaters, and post bariatric surgery they start having more proteins, but there is no other reason to say why the sleeve was working so well. And the de novo GERD was seen in about 15.7% patients. So this is a kind of situation we are seeing, that sleeve gastrectomy has been working well even after 5 years, except the discussion on de novo GERD, which Michelle has put in perspective already. Could we go to the next slide, please? So Mohit, taking discussion forward, since de novo GERD has come, Praveen will take this question with you.
Yeah, so I think that was a beautiful sharing of experience from none other than Michelle Gagnier. And I think how over the years, each procedures, we tend to learn from each of the procedures, and bariatric has been a big journey wherein we've been moved from kind of malabsorption to restriction to malabsorptive restrictive to restrict. And then the move has been quite interesting, and sleeve for sure has found a place for long. And I think being a popular procedure for long, I think will continue to be a popular procedure for long. However, as Michelle and Dr. Raman had just pointed out, GERD, de novo GERD continues to be a big trouble with regard to sleeve gastrectomy. And then I think more and more discussions, more and more data are now emerging with regard to de novo GERD. So Mohit, the question is to you. So do you think, considering all the advantages, let's leave it aside, just this de novo GERD, does it have a potential to cause a sleeve decline in the years to come? What is your thoughts?
Yes. So Praveen, I don't think so. De novo GERD in itself cannot cause a blow to the sleeve, because as Dr. Michelle said, that we have GERD in almost all the bariatric procedures. I mean, talk to me. I've been endoscoping all my patients post MGB. MGB has a lot of bile reflux, if not GERD exactly. Gastric bypass patients have good incidence of GERD. I think it's there in all these procedures. I think GERD in sleeve is a little overhyped. It's because we wanted to find an ailment in the procedure, and I don't personally feel that you can decline the popularity of the sleeve just because of GERD, because first of all, it's not that you do another procedure and get away with GERD. And the second part which I would like to mention is that we have been saying that a gastric bypass probably is a treatment for GERD, but I have some incidence of GERD in my gastric bypass patients as well. At the same time, we have to understand that for surgeons to perform a Roux-en-Y gastric bypass or a mini gastric bypass, it requires some technical skill, whereas sleeve gastrectomy is widely performed by many other minimal access surgeons who will not have primary bariatric practice. So to be very specific to your answer, de novo GERD alone cannot cause a blow to the sleeve. At the same time, it would be important to mention here that we need to train bariatric surgeons to first understand the importance of endoscopy, second, learn it, and third, be committed to do a good surveillance on their sleeves and a mini bypass, and now even the gastric bypass patients, to find out the real data, which will give an answer to your question in near future.
That was wonderful, Mohit. I mean, I think I have the liberty to take maybe a point from another panelist. Do you have any other alternating viewpoints to what Mohit has shared? I think, Dr. Michel, please. I think you're muted.
Yes.
Yes,
Yes, I wanted to say something. There is a paper in press in SWORD. Again, there are great papers coming out, and that is the revision of sleeve in France. France is able to capture all the data from the country, and sleeve was performed in France before probably most European countries, and they have the largest experience. In fact, they do more bariatric surgery per capita than in the United States. Over a period of 10 to 12 years, 12% of sleeves have been revised. That's a big number. But guess what is the main reason for sleeve revision? It's not reflux. Reflux, the main reason for revision of sleeve is weight regain or inadequate weight loss. And that is nearly 90% of all the sleeves that are being revised. So if we're saying that that reflux is so bad, we should be seeing a lot of sleeve being revised for reflux, and that's not the case in a country where they capture everything, and that is very, very interesting. Now, in their revision for weight regain, 3/4 of their operation was Roux-en-Y gastric bypass, and I think that that's the wrong strategy. It doesn't give such a good weight loss. I hope that the French surgeons have realized that. Perhaps they did not have more choices in their strategy, but this is something that hopefully they will catch on.
Oh, that's
Parveen, can I make a comment?
Sure, please.
I do agree with both Mohit and Michelle that the simplicity of the procedure plays an important role, and I think one of the reasons sleeve gastrectomy has become so common in the US is that training programs in the US do 90% sleeve gastrectomy. So graduating residents and fellows don't have any experience doing Roux-en-Y gastric bypass. And it's not only because of the complications of Roux-en-Y gastric bypass, but because of the simplicity, more and more surgeons who did not do bariatric surgery in the past are doing it. That's the first comment. So the fact that the numbers are increasing don't necessarily mean because it's a better procedure or Roux-en-Y gastric bypass is worse. The same analogy could be made to laparoscopic colectomy. Only 1/3 of colon cancer is done laparoscopically. only a third of ventral hernias are done laparoscopically, and it's because of the difficulty in training. I just want to point out as my second comment to the comment of reflux and sleeve. IPSO is coming up with a position statement very soon about Barrett's. And I encourage everyone to look out for it. And in this position statement, it is clearly stated that looking at the literature, that sleeve gastrectomy has higher rates of postoperative de novo reflux compared to other procedures, and in particular, Roux-en-Y gastric bypass. But I think the most important thing to note is that the incidence of Barrett's in the general population is in the 1% range. And looking at the entire literature, the incidence of Barrett's and sleeve gastrectomy is in the 4% range. So it is more than double for sure. And at the end of the day, this incidence of Barrett's might not be as high as reported in some studies in 13, 16, 18%, but it's not the same rate as developing Barrett's after other procedures like Roux-en-Y gastric bypass. So the reasons why things are performed more does not mean it's simply because it's better and the other procedures are worse.
Okay, thank you to the panelists for those comments. And I think we certainly agree that there is definitely an increased incidence of gastroesophageal reflux, esophagitis. But of course, as Dr. Michelle pointed out, that is not the number one reason for revisions around the world. Yes, we are having increased reflux, especially that's been discussed in the recent years with more and more data, with more and more long-term evidence. This is one of the papers from CK Wong's team, where they noted increase in reflux of prevalence of GERD symptoms up to 47%, erosive esophagitis of 66%, and even hiatus hernias to 27%. And we had one of our own data that were done where we did a pH and an impedance along with the manometry, where we did find that the entire 24-hour pH changes, including the D-Meester score, significantly going up post-sleeve gastrectomy. And using the impedance, we did see not just the acid reflux, but the non-acid reflux to go up. Yes, refluxes have been high, de novo reflux have, but then the popularity of sleep is still continues to be there. And as Dr. Michelle and Mohit believes, yes, that alone may not cause sleep decline if we work something towards it. And that is the next question, which is for Dr. CK Wong. Can we do anything about reducing the de novo GERD during sleeve gastrectomy or post-sleeve gastrectomy? Technically, can we do something more about it? Over to you. Dr. Wong?
He seems to be muted.
Okay. Good evening, everyone. Okay. Nice to meet everyone on the air. Lovely to see everyone is safe in this condition of COVID-19. First, I want to talk about how to reduce the de novo GERD after sleeve. I think that about 8 years ago, when we start to do sleeve, after 2 years later, we really find that the reflux is a very important issue for sleeve gastrectomy. And as you see in the presentation, you will see in my practice now, sleeve-based procedure, including some sleeve plus procedures, account about 70% in our practice already. And including the revision of the sleeve, mostly is because of reflux or weight regain issues. The Roux-en-Y bypass is count about 60–70% as the most numbers of our revisional procedures for sleeve gastrectomy. So in fact, sleeve, I believe that is a good procedure that can have a good weight loss, reduce the long-term comorbidity from the malnutrition issues. But if we look at the mechanism of the reflux, in our paper, we also mentioned that it could be coming from the high pressure, coming from the strictures, coming from you cutting the EC junction sphincters, or even the new onset of hiatal hernias. So how we really can prevent the de novo reflux after sleeve gastrectomy? Here, I would like to mention a few points. The number one is I recommend all the surgeons preoperative to do evaluation of your patients on endoscopy to see if there's any Barrett's any reflux, any hiatal hernia issues before surgeries. Then you can decide whether you want to continue to do the sleeve gastrectomy. Number two is that we need to do the correct sleeve gastrectomy.
Your voice is cracking, Dr. Huang. Praveen, are you able to hear?
CK, can you just, we are
without structural issues, especially in the ankle of his don't
CK, if you can switch off your video, we are not getting your voice clearly. CK, I think there is an internet connectivity problem.
Yeah.
He
So,
needs to reboot.
and all
can you switch off your video, please? I think then we can hear you better.
Dr. CK, we're not getting your. Can you just switch off your video so that the audio will become better? Dr. Kritika, can you just mute CK's audio for a while? Maybe I can take this here.
not very clear.
No, we've just lost you. I think your signal is a little weak on your end.
Have you switched off your video, CK?
Can you hear me?
Yes.
Ask him to reconnect.
I think this is better now. We can hear you. CK? No.
Now you can hear me.
I think there is a connection problem.
Can you hear me?
CK, there is a connection problem. I think you will have to reconnect, and then we can take this question with you again.
Yeah. So,
Praveen.
I think CK would have wanted to say this is what I believe, because he's one person who believes in doing technical reinforcement to the G junction to improve GERD or to reduce the incidence of GERD. The ligamentum teres cardiopexy is one such technique that he's been very popular, and a few other surgeons around the world, including myself, we have been doing. So I think the addressing the gastroesophageal junction may be something we need a lot more literature upon, a lot more work that we need, or all of us need to do to probably, of course, we do not have much data at this point that whether these techniques do reduce the reflux, but however, we've been getting some interesting data that is emerging from around the world with regard to different techniques. One such technique is the ligamentum teres cardiopexy. We have the placement of the link system. However, predominant of the data has been with regard to placement post-sleeve gastrectomy, where somebody has developed a reflux. Of course, if we can work on more data on placing into a primary sleeve gastrectomy, will be quite interesting to know about it. And of course, trying to do a kind of a Nissen's fundoplication, wherein leave the fundus to wrap around the lower end of esophagus, called the Rossetti-Nissen's fundoplication, is one such technique that's been published in literature. And I think I found this interesting, I'm not sure whether I can call it crazy, but then hiatus hernia repair, or maybe place in a urinary bladder matrix graft, basically a biological material that the surgeons have used to augment the GE junction. So basically, I think we need much long-term data. I certainly agree with Mohit and Michelle that just reflux alone cannot cause decline, because the advantages are so much that we will continue to play, but then we need to work on other techniques.
CK has logged in, Praveen. You can ask him.
CK, I have taken the liberty to share some data on the various reinforcement techniques that's available in literature about the ligamentum teres cardiopexy also, which I know you do a lot of it. I've just mentioned about that, but I will probably leave with you for a while to share your views. CK? Hello?
Hello, CK? Are you with us?
Dr. Goel, the audio is not connected for him as of now.
Okay, so I think we will move on.
Trying to reconnect.
Okay.
I would like to say something regarding new data on the understanding of the reflux. after sleeve gastrectomy. There is a very interesting paper that comes out from IRCAD Strasbourg, written by Bernard Allemagne and Peretta, which talks about the angle of insertion between the esophagus and the stomach. And that angle is changed by 15% after sleeve gastrectomy. And it's proposed as the mechanism for reflux. And it's bringing an interesting point for restoration of the angle of insertion as a possible modality for decreasing reflux of sleeve gastrectomy. So I encourage everybody to read this paper. It's an interesting paper that looked at CT scan reconstruction of patients before and after sleeve with the angle being measured. This is, I think, will bring new ideas on reconstruction of this angle with different methods to not have this reflux anymore. And I think that these are attempts, the ligamentum teres, the pexi to the base of the right and left grooves are examples of restoration of the angle or attempt to restore the angle.
Michelle, since you are talking on this issue and you're doing almost 85% sleeves, I would like to know if a patient is evaluated before surgery and patient has a clinical reflux or has an endoscopically diagnosed reflux disease, what would be the criteria to say that this patient we should not do a sleeve? I mean, is there any criteria to apply?
Well, for sure, if you have an incompetence of the sphincter that you've measured, I don't think a sleeve is a good operation. That should be discarded, okay? So measurement, if you have proof, measurement of incompetence of the sphincter, you should not be doing a sleeve gastrectomy. Now, you should be doing a Roux-en-Y gastric bypass, but there's a way to do your Roux-en-Y gastric bypass in these patients. The pouch should be almost at the G junction, so you don't have any large pouch and you don't have any acidity that is going to be refluxing, because the Roux-en-Y is not correcting the sphincter. So you've got to be cognizant of these little particularities. I see people do Roux-en-Y gastric bypass and then they have a large gastric pouch, and this patient is going to be back on medicine a few months or a few years later.
Okay. CK, are you back with us?
Yes. Yes.
Yeah,
can you hear me now?
Your opinion, yes, much better.
Okay, sorry.
No problem.
Here I want to mention one important point that the new reflux happened after sleeve gastrectomy. We recently explored those who have reflux issue, then need the revisional surgeries. Before, I think most surgeons routinely compare these patients to go to the Roux-en-Y bypass. But in fact, when you are trying to evaluate these patients after sleeve gastrectomy, then you do the CT scan, you will find 90% patients have the new hiatal hernia and the migration of gastric tube. So for those who have the migration, we found that most of the patients have a new hiatal hernia, and also the tube, including EC junction, can migrate 3-4 centimeters above the EC junctions. When you bring it back down and repair the hiatal hernia, you will find the patient's reflux can be resolved after your surgery. So how to prevent the migration issues? Of course, we know that how to do a perfect sleeve. A lot of surgeons have talking about this, including the right sleeve, no rotation, there's no strictures, and don't cut the EC junction. But one thing is that how to reduce the possibility of the migration and new hiatal hernia. So as you see, the paper have been published that talking about ligamentum tears for revising the migration issues of sleeve. I think right now we should consider to do at the same time intraoperatively to how to fix this gastric tube to prevent the future migrations. So don't over dissect the EC junction, and also don't neglect the hiatal hernia before surgeries, and also fix the gastric tube in the intra-abdominal positions using the ligamentum tears or using the gastropexy to the cruise. I think can eventually, if you future I think can prevent the reflux issues in sleep gastrectomy.
So CK, are you doing this ligamentum teres in primary sleeve, or are you doing it in those?
Yes.
Yeah.
In fact, about 1 year ago, we routinely do ligamentum teres for primary sleeve gastrectomy. But right now, we find a more easy way to fix the tube. In fact, when you finish the sleeve gastrectomy, you can suture the EC junction angles gastric tissue to the leg cruise by 1 or 2 stitches, can prevent the migration issues. So right now we use the Docplexus as a primary procedures, routinely 100% in our patients. Then if the patient develop the migration again, maybe 2 or 3 years later, then we can repair hiatal hernia, use ligamentum teres for revisional surgeries.
Okay. Thank you. Thank you so much. So we move on to the next question. You know, the OAGB. This is a big issue in our country, that the OAGB or MGB is growing more and more popular. It has already overtaken Roux-en-Y gastric bypass, and it's getting closer to sleeve in numbers. So is that the reason why the sleeve numbers are declining, Deep? I know you do mostly sleeve. We'll show the case mix, but what is your take on OAGB versus sleeve?
So, Dr. Raman, thank you. Let us first understand, why are people trying to change from sleeve to any other procedure? Is it because that sleeve is an inferior procedure and OAGB is a superior procedure? Answer is no. It is twofold. One, people think that if they continue to do only sleeve procedure, they are not taken seriously as a bariatric surgeon. There's a more glamour in doing a much more difficult procedure. So that is one. And second, RYGB is probably more difficult to do than OAGB. So they feel that OAGB fits into their perspective from the point of view that they will be able to do a procedure more than sleeve, and it is still simple. So that is the reason for most of the people shifting. Then let us look at, people have yet not started reporting their OAGB complications. And I was very glad to hear Mohit today when he said that they are seeing around 15% of the marginal ulcer incidence. And these marginal ulcer incidence of perforation is much more as compared to RYGB. So coming to the point of Dr. Nimeri, when he was saying that Barrett's is found in around 4% of population as compared to 1% of general population. And here we are talking about a procedure where there's a 15% incidence of marginal ulcer versus 0% in normal population. So I mean, there is no comparison at all. And I'm sure gradually people will realize that it is not a particular procedure which is going to be a success story. It is a program. It is the behavior of a patient. It is a lifestyle change. And as a particular program and a surgeon matures, you realize that it is not about doing more in surgery. It is about doing more in your program and training your patients. So these all factors will come into play. And as Michelle said again, that GERD is largely a scare, not a reality as it has been reported in literature. I'm not saying that there is no GERD. It is, but the incidence is not as high as been reported. So I think OAGB will eat into RYGB incidence rather than into a sleeve incidence. And as more and more complications will be published, as newer surgeons are adopting bariatric surgery, they will adopt sleeve, which is a much simpler and more physiological, less complicated procedure. So in my opinion, in coming time, the number of sleeve are going to increase, not decrease at all. And if at all it is going to make an impact, it is going to be number of RYGB which are going to go down, not sleeve.
Okay. I think, Deep, you have a valid point. The only concern is we are looking in percentage terms. But in real patient terms, if you do a sleeve on a 21-year-old girl and 3 years down the line, she comes with a 3 to 4 centimeter hiatal hernia, and you tell her that now you need another surgery, it's a major issue because they don't expect that. I completely agree with what Michelle's saying. Even with Roux-en-Y gastric bypass, the reoperation rates are high. But giving a hiatal hernia where you tell them that the stomach has migrated in chest and you need an another surgery is sometimes difficult to explain, and that is what most of those who have been doing large number of sleeves are concerned.
So what is happening, Dr. Raman, just to comment on this point, I take your point, but a very few percentage of these patients will require either a reoperation or they will be put on a long-term proton pump blocker, which would have happened otherwise also in a percentage of population. So I think it's not disregarding a particular procedure. Yes, a very small percentage of patients may have problem with sleep. That's acceptable.
Yeah. And what Praveen just showed those figures, the sleeve numbers kept on increasing. It's basically the OAGB is eating up, as you rightly said, in the RYGB numbers. Okay, next please. Yeah, so this goes on to show that though the OAGB remains is an effective procedure, this is the consensus statement. But there are many issues. There were many issues which were not in the consensus zone, even in OAGB, and maybe we'll discuss that in some other platform next time. Next, please. Dr. Kerrigan, so if we move on from the reflux issue, as it has been explained beautifully by Michelle, that it is there, but it's not a very big deal. We have major issues even with other surgeries. Then the second issue is weight regain, and weight regain remains a whispered issue about sleeve gastrectomy. So can we do something that the outcomes improve? Can we do something beyond a standard sleeve procedure to improve the outcomes in terms of weight regain?
Yes, I think I said earlier on that it's my view that the sleeve gastrectomy has a great advantage of being a very easy operation to do, but it is also a very easy operation to do badly, because technically the kind of patients we see coming back with problems after sleeve gastrectomy are either because we do have a lot of health tourism in the UK at the moment, particularly, and we see patients coming back with a sleeve that's been narrowed at the incisura, which can be a challenging problem, and patients presenting with quite severe nutritional problems. Or we have people who just get a very poor result because the posterior fundus hasn't been mobilized properly, a large fundus has been left behind, and the patient doesn't do well. So it is an operation that it has the beauty of simplicity. I agree. And I actually agree completely with Michelle about the reflux issue. I think everybody panicked about the Genco study of showing the incidence of Barrett's after sleeve, but the important thing is that Barrett's is simply a risk factor for esophageal cancer. And somebody who has low-grade Barrett's, it does not necessarily carry a particularly high risk of developing esophageal cancer. We need to know the number of people who develop severe high-grade dysplasia Barrett's after sleeve gastrectomy. And as Michelle's inferred, that is probably very, very few patients for what we know so far. So I think the reflux is an issue. I think the problem is probably weight regain. And I think surgical technical factors, as I've just explained, are one of the things. I think the other thing for us, and you may disagree with this, but this is our view, is patient selection, because we said there's no such thing as an ideal patient, and some patients have a predominantly high sweet intake. They enjoy liquid, meltable, dissolvable sweet things, chocolate, cake, anything that crumbles up small that's full of sugar. That is the thing they like. And you can work as hard as you like on your program with the dietitians and the psychologists, but sometimes that is a difficult thing for some patients to change. And so that is one of the reasons why we would nudge a patient away from a sleeve towards a bypass, is if their preference for food is clearly very heavily weighted towards simple sugars, because we know that the dumping syndrome, they're likely, but not always, but likely to get after Roux-en-Y or mini bypass, is actually a form of aversion therapy for them. It's going to put them off doing that. And that may be one of the things that would potentially prevent a patient from regaining weight after a sleeve, because with a sleeve, they can still eat all of those things. They can still eat ice cream. They can still eat anything that crumbles up small. They can still eat chocolate. And there's no negative for them to doing that. And so some of these patients, because of that natural dietary inclination, I think maybe aren't going to do so well with a sleeve. So technical factors, getting that right, not leaving a big fundus at the back, which we see all the time when patients come back for revision of sleeve. And secondly, patient selection based on their dietary habits, because it's very, very easy to break a bad habit like that. Very easy to form one, but very difficult to break it.
Okay, I think that is very illuminating, because patient selection has been discussed in some studies. Praveen, can we go to the next, please? So this study from France, where they because the government mandated MDT team meeting before surgery, and they found that whenever the MDT teams meetings were there, the results improved, the complication rates reduced in those centers where MDT teams meetings were happening, and it is not related to weight regain alone, but so I think the preoperative workup of these patients is important. But then what about the post-operative care? So we have one of our publication on portion control eating, and this was published 2 years back, and where we have shown that, with the so one of the mechanisms most of the obese patients develop before surgery is that all of them eat a smaller meal than what they can eat, and that's an inherent built-in mechanism in obese to eat less so that they can maintain weight or they can try to lose weight. Now, after surgery, this mechanism of saying that you can eat till you are full, till you are satiated, is not a natural thing for them. And this is breaking a defense mechanism which was already there in these people. And we have been following this for a long term. And as you can see, that this is at 2 years, percentage weight loss is substantially higher. And we would be very happy to, this is for patients of 2 years, for patients who underwent surgery in 2012 and 13, almost 425 patients. And the percentage excess weight loss is substantially higher in sleeve group and in root gastric bypass. So I think besides doing a good sleeve, there can be other mechanisms to do this. And one of the group in US is now following this portion control in 50% of their patients. And they're following the standard protocol in rest of the patients to see whether to check this hypothesis. Can we go to next slide, please, Praveen?
So I think until now we've been talking about improvising the outcomes of sleeve gastrectomy, both technically and involving the multidisciplinary team. But I think when we know what we should be doing, we also need to discuss when we should not be doing something. I think we've been talking about GERD, de novo GERD as being a possible roadblock in the future of sleeve gastrectomy. But then if there is an existing GERD, the question is to you, Dr. Nimeri, is it an absolute contraindication to you? Would you do a preoperative endoscopy? How would you approach such a patient?
Thank you, Parveen. I think that the most important thing is to quantify objectively reflux disease, because reflux disease is a disease that some patients have heartburn without reflux, and some patients have silent reflux. So if someone has reflux disease, they need to get an endoscopy before surgery. If the endoscopy shows grade C, LAC, or D esophagitis, or it shows Barrett's, those patients, I don't think it's appropriate to perform a sleeve gastrectomy in them. The literature shows that sleeve patients have proximal migration of their Z-line in many endoscopic studies, and manometry studies that were done in sleeve patients shows that the lower esophageal sphincter is lower and the pressure within the sleeve is higher, especially when patients eat. So if the patient has objective evidence of reflux of grade C or D, or they have Barrett's, we do not do sleeve gastrectomy. Now, if the patient has a normal endoscopy with symptoms, or if the patient has LA grade A or B esophagitis, we try to quantify the symptoms and see how controlled they are with PPI and how symptomatic the patient is. If someone is quite symptomatic, we might still do a pH study if they're interested to do a sleeve gastrectomy. And if they have objective evidence reflux of reflux on the pH study, then we do not do a sleeve. But if the patient's reflux is not severe, we just counsel them that, and they want to do a sleeve gastrectomy, we recommend a bypass if they have reflux. But if they want to have a sleeve gastrectomy, we counsel them that there is a chance their reflux can get worse. And if they still are interested to have the sleeve and their symptoms are controlled, we will proceed then. But quantification of the reflux objectively is the most important thing to do.
Yeah, I think I certainly agree, because there has been an existing debate for quite some time now that whether preoperative endoscopy is it mandatory or not, but certain societies have really not been endorsing that. But I think, as you've clearly said, preoperative endoscopy is important, and ruling out GERD is very important, because now when a normal patient's increasing chance of de novo GERD is there, and I think with the patient with an existing GERD, doing something more worse is something which would be impacting significantly on the quality of life. And a very recent publication in the year 2020 that's come forward, whether preoperative upper GI endoscopy should be essential or optional. And I think the patients who were subjected to bariatric when they underwent an endoscopy, significantly high incidence of peptic ulcer, reflux esophagitis, Barrett's esophagus were picked up, which obviously would go against a sleeve gastrectomy. So it was finally concluded that preoperative upper GI endoscopy should be considered not an optional one, but an essential in all of these patients prior to bariatric procedure. And I think we as surgeons need to, because there are practical issues in getting endoscopy done in all our patients in certain geographical locations, in certain geographical practice, with insurance, etc. But I think we as surgeons need to find ways and means to make sure that we get it done in all our bariatric patients prior to bariatric surgery, because GERD is something which we need to be very careful about. In that regard, going on one step further, Mohit, the question is to you. Of course, GERD is something we all know we shouldn't be doing asleep. But then, is there any other condition or any other patient where, excluding GERD, let's leave GERD out of the equation at all now, any other situation where you wouldn't be doing a sleeve, because you are somebody who does a variety of bariatric procedures where you would not do a sleeve? Can you just elaborate on that?
Yeah, I would not do sleeves in cases where I think the patient deserves a mini gastric bypass or a bypass. So, somebody who is very severely diabetic, who has a poor insulin reserve, will not get a sleeve. He would be a candidate for a gastric bypass or a mini bypass. Somebody who has this diabetes and can afford the cost of the protein supplementation, is capable of taking a good amount of proteins in the form of non-vegetarian food. Why should that patient get a sleeve? At the same time, if there is a patient who is super obese, deserves one anastomosis bypass, if the same patient has no liver diseases. So I think a normal liver, severe diabetes, ready for a follow-up, affordability in terms of protein supplements will divert me from a sleeve towards a mini bypass or a bypass. I have my own set of complications with sleeves, not primarily in terms of leaks, but we have more amount of thromboembolic complications with sleeves, specifically mesenteric vein thrombosis and splenic vein thrombosis and others. So in certain thrombogenic conditions, we have not given sleeve to patients, and we have gone to the extent to give a mini bypass. That's the second situation. The third would be, since we have a huge experience with mini bypass, sometimes I feel that a mini bypass can be done in lesser amount of time than the sleeves, specifically in patients who have a difficult dissection near the GE junction. These are the three situations where I won't give sleeve to the patient, despite even if the patient does not have GERD.
Thank you, Mohit. Dr. Kerrigan, can we reserve the discussion a little bit towards the end, because we're running out of time? I'm sorry, because there are another 2-3 questions. So we'll definitely come back to you at the end. We have a lot more questions that we discuss. But I think, as Mohit pointed out, there are various other conditions wherein if you think other procedures may be better suited to your patients, we need to look into it. And young surgeons who are watching this, yes, there cannot be much absolute contraindications to sleeve gastrectomy. other than uncontrolled coagulopathy or a general anesthesia or a severe psychiatric illness. And of course, GERD and Bariatric esophagus would continue to be the contraindications. In other situations, yes, so they are going to be gray areas. You need to work with teams who have high volumes, and over time with experience, what would rightly suit your patients. Over to you, Dr. Goel. So you're muted.
CK, a lot of discussion about sleeve plus procedures. Now, the problem with these procedures that we discuss is that it still remains a sleeve, and so why sleeve plus? Is it's only for additional metabolic benefit or weight loss benefit?
Yes, I think right now we have looking into a lot of published paper about whether sleeve can have a very good long-term weight loss. More weight regain issues coming from the sleeve alone. Number two is about the diabetes remission because of the long-term weight regain and also the recurrence of diabetes or incomplete remission of diabetes after sleeve gastrectomy. Encourage us to do more sleeve plus procedures. I think the concept of sleeve plus, in fact, is coming from the duodenal switch. This is a sleeve with duodenum jejunal bypass, but have a lot of malabsorption issues. Looking at the gastric bypass versus sleeve, the comparative study mostly showing the bypass has a better long-term result in the weight loss and also the diabetes remission. So if we want to abandon the Roux-en-Y gastric bypass, as time goes by, encourage more surgeons to do the sleeve. I think to adding the bowel bypass in sleeve gastrectomy might be one issues and also important options for most surgeons. So in fact, sleeve plus right now in Asia, including Japan and Taiwan, we do more sleeve with duodenal jejunal bypass. So we mostly use this in the long-term diabetes and those who have decreased pancreatic function. Less than 50% cases, we adding the duodenal jejunal bypass. And also in the our practice, we also doing some cases for those who have the super obesity cases. If the patient don't want the Roux-en-Y bypass, we use the sleeve plus the jejunal bypass for the patients. The comparative study from us showing the 2 years result compared with the Roux-en-Y gastric bypass is almost the same, but much better compared with sleeve alone in the weight loss. Yeah. So I think right now, because sleeve has become the most popular procedure in the whole world, so I think sleeve plus might be one important trend for the futures. At least would have almost 20 to 30% in your practice, I think.
Yeah. So CK, its position as a second step surgery or second stage surgery is understandable. But when if you're doing it as a primary surgery, how frequently do you see reflux related issues? Because, you know, it ultimately remains a sleeve. So do you see the same volume of reflux as you see in just a sleeve?
I think the reflux is not a problem with that, because in fact, you adding like we do the loop duodenal jejunal bypass because the pylorus is intact. So in fact, the first portion of duodenum still remain the same. There's bile, there's some acid from the sleeve itself. So I think that we did not see the bioreflux issues in the sleeve with loop duodenal jejunal bypass. And the reflux, I think, is the same as the sleeve alone. So I don't think that, but so we also did not recommend sleeve plus procedure in those who have severe reflux issues patients.
Okay. All right. Praveen, next slide, please. Is Dr. Nemeri still there? All right. So CK, we can continue with you on this. There's obviously the major issue of leaks after sleeve, and gradually the numbers are reducing worldwide. So can you briefly summarize what could be the ways to reduce the leaks? Because surgeons who are beginning in their career are scared of leak of a sleeve. And the numbers, the percentages have gone down significantly. So what can be done?
Okay, I think sleeve leak is always related to the experience of surgeons. So most surgeons, when you start to do the sleeve, when you think this is a simple procedures, you can encounter very severe and very bad nightmares from the leak. Sleeve leak coming from a few reasons. Of course, when you make a wrong sleeve tube causing the strictures, the uneven pressures in the upper and lower sleeve tube can make the leak. The second is you make the torsion of the sleeve gastrectomy because of after you finish the sleeve tube is not straight. And we routinely fix the sleeve tube to the retroperitoneal fat to be sure that there's no torsion happens. Number three is too much devascularization near the EC junction, especially for the first branch of the esophageal branch to the gastric tube. In the near the EC junction, we did not do devascularization over that. Another problem is that the staple, I think right now the staple has gone through a few years that become more safer, including the tri-staple, including the power echelons. So all the efforts from the company try to make the staple more safer and also to reduce the human errors to become a powered one. So I think to use the right instrument and also the right staple and including the height of staple is also important that to reduce the possibility of sleeve leak. And number five, I think is another issue is about whether we need to oversaw it or doing the implications. But till now, still there's no any randomized trial, large one, to showing that there's a difference. If you do implication or oversaw, can reduce the leak rates. In average, in experienced surgeon, the leak rate after sleeve is less than 1%. So I think look into all the data right now. If your sleeve leak rate is higher than 1%, I think you need to go back to your teacher.
Yeah.
So, and if your leak rate is less than 1%, I think that right now is something that we cannot solve yet. So I think still related to some circulation, some tissue management, and also those who from the staple problems. But eventually, I think the leak rate 1% is reasonable right now for most surgeons that when you are doing the sleeve.
I think that's so well said, CK, because as we talk to our fellows that treatment of a leak is not an option. Prevention is the treatment of a leak. So I think
yes.
This is so important to have a very low leak rates because treatment is really difficult. It's a nightmare, and as this study shows, that it's very expensive, morbid for the patient and morbid for surgeon as well. So it's better to, as CK rightly said, if you are having a leak rate more than 1%, you go back to your teacher. So I think this is the way to look at it. We are not discussing the treatment of leak here today. We move on to the next slide, please. And Deep, briefly, we know your case mix. You do majorly Roux-en-Y gastric bypass after sleeve. So what is your procedure of choice and why?
So, Dr. Raman, it will largely depend upon why are we revising a procedure. If you are revising for complications like leak or stricture, then RYGB is my procedure of choice. And if you're revising for weight regain, then I need to see whether the first procedure which was done, did it give good results or not? And if imaging shows that there is a dilated pouch, dilated sleeve, and the first sleeve gave good results, I actually would do a re-sleeve in this particular patient. And if the first procedure did not give adequate results, then we need to look into the cause, whether the patient was compliant or not compliant. And if the patient was compliant, then my choice would be to do some sort of a bypass. And my first choice would be RYGB, unless patient has a lot of comorbidities, relapse, and patient is a non-vegetarian, he can supplement his protein, and he can be assured that he can come for follow-ups, then I would do an OAGB. And if it's a non-compliant patient, I tend to offer no surgeries. I will try my best not to offer any surgery unless I am sure that he is going to be compliant for the second procedure.
All right, does anybody wants to add anything before we move on to the next? Next slide, please, Praveen. So this is exactly what Deep has mentioned. If there is reflux or stricture, then Roux-en-Y gastric bypass, large dilated stomach, either a re-sleeve or a Roux-en-Y gastric bypass, and failure of restriction, then everything is open and we are not sure which one is going to work well. Okay, next slide, please. Praveen?
So, before we conclude the session and we take the other questions, I think with having Michelle here is really fortunate. So, because you've been the biggest pioneer for proponent of sleeve gastrectomy, I would say, and what sleeve gastrectomy is today, you hold a big responsibility. However, you have carried it for long, but I think it's time for the other young surgeons to carry the torch to make sure sleeve gastrectomy continues to be on the top. So, Dr. Michelle, one piece of advice from you for the young surgeons watching this on sleeve gastrectomy. What is that they should do right?
Thank you. Thank you. I was not expecting this question, but what I say to my young trainee is not to make the sleeve too tight. I think that it's a mistake to try to get the best results when you start your practice, when in fact you should have the lowest morbidity and mortality in your practice, so that you will be able to attract more and more patients. So I would say use a slightly larger bougie than you would think, so that you're not going to get strict curves. I would encourage you to do sleeves that are a bit not too aggressive, and as you gain experience and you want to improve results, then you can start tightening things. But that's my only good advice, is to take care of the patients and try to operate with the least amount of complications and mortality, and not to worry so much about getting the best percentage of excess weight loss.
Any points?
Can I just make a comment?
Yes, please, Doctor.
I remember in 2000, I visited Mount Sinai. I was working with Michelle for 3 months. And that time I used to see Michelle doing duodenal switches and bypasses. And I asked him before I was leaving that, should I start this in our country? And Michelle said, wait, this is too morbid a procedure at this point of time. Wait for a couple of years. Some better procedures are coming. And how true it is today that, we have moved from those era where a pioneer is telling a young surgeon not to start a bariatric procedure in your country, and to an era where we are saying that today bariatric surgery has become so safe and so simple after training well. Thank you.
Thank you.
Absolutely. I think before we take the questions, trying to conclude all the discussion points together, because we as moderators need to give conclusive statements. I think sleeve is definitely simple and reproducible, no questions on that. We have excellent outcomes comparable to other procedures. However, strong multidisciplinary team is important for optimizing the long-term outcomes. However, sleeve leak is dreadful and expensive complication, which we need to make sure it's lesser than 1% as CK has put it on, or go back to your teacher. Definitely, we need to be looking at increasing revision rates. However, it's not primarily because of GERD. Its weight gain has been one reason there's been increasing revision rates. And de novo GERD is something we need to work upon, probably improve our techniques, where we need to work upon long-term data to see how we can reduce the incidence of de novo GERD, which is probably will continue to be the biggest roadblock for sleeve gastrectomy, although it's very popular, and we all believe will continue to be a very popular procedure for some time to come. Of course, we will be taking some important questions. Over to Dr. Raman Goyal. Maybe you can take all the pending questions that we have.
I think, Praveen, you can stop the screen share so that the faculty is visible. I'm glad that Dr. Nimeri has joined back. He made some arrangements so that his patients are seen. So, Dr. Nimeri, to start with you, the first question that came from the participant is, what's the most appropriate way of avoiding post-op bleeding in a sleeve gastrectomy? So what extra measures would you take to avoid bleeding in sleeve?
Sure. Thank you. One important thing is to make sure that if the patient is on Plavix or aspirin, that you stop those before surgery. And then you need to do something to the staple line. I think if you leave the staple line with no staple line reinforcement, no oversewing, and no clipping, you will have higher incidence of bleeding. And the way the staple line looks at the end of surgery might not reflect the incidence of bleeding, because the patient, there is insufflation in the abdomen and their blood pressure is controlled by the anesthesiologist. After surgery, you'll desufflate the abdomen and they might get a higher blood pressure for pain or any other reasons. That is why the most important thing is to do something to the staple line. We have found laparoscopic suturing of the staple line in a Lambert fashion to be quick and effective and cheap. Does not add any cost to the procedure, and it adds about 10 minutes more. And that's what we do. We oversew the entire staple line in all patients, and that can make the risk of bleeding very acceptable, despite a very aggressive strategy for VTE prophylaxis. Because we have to remember, most surgeons worry about bleeding because the rate is about 3%, but surgeons don't worry about VTE, and the rate is 3 in 1,000. But VTE could be life-threatening.
Anybody wants to add anything on the bleeding in sleeve, please?
I'll just make a comment that we don't use, I think there's no doubt in the literature that staple line reinforcement reduces the bleeding rate after sleeve gastrectomy. But we actually don't use it. We have a simpler technique, and we're about to publish a study in about 2,500 patients demonstrating this, of just using tranexamic acid. So the patient gets a gram of tranexamic acid at induction, and they get 2 further doses 8 hours apart afterwards. And we found that to be equally or more effective than anything else we've tried.
Great. So Dr. Nemeri, we also had a 2% bleed rate after sleeve till about 2 years back. And then we started doing a simple thing of raising the blood pressure on table in every patient, asking the anesthetist. And 100% of the patient had a bleeding staple line in front of us. So I think now we have been able to reduce it substantially. We have not analyzed the data, but we don't re-explore patients now. So I think what you mentioned is so valid, that the post-operative, especially during the extubation, the blood pressure goes up and these patients bleed, and then they present in post-operative period. So I think if there's no other addition, we can move on to the next question.
Yes. I was going to say, Ramin, that I think what Dr. Kerrigan said is understated. I've been using, again, also tranexamic acid for a couple of years, and I have not re-explored or transfused anybody in more than a year. And that makes a big difference if you're contemplating to do outpatient sleeve gastrectomy, because that's the trend in many ambulatory surgical center that we have in North America. Patients are being discharged the same day, and my worry was always bleeding. So with tranexamic acid, it's changing the whole game. And that's in addition to what you are already stating and doing. I was worried that tranexamic acid could increase the rate of pulmonary emboli in DVT. And indeed, we had some patients, but they were not life-threatening. And it seems that maybe the incidence looks the same or slightly higher. I'm not sure if Dr. Kerrigan has any deep vein thrombosis with the use of tranexamic acid, but it's a cheap drug, and I think people should consider this worldwide.
Yeah, so we're hoping to get this published very soon. And in the study, I think about 2,500 patients, we split patients into 2 groups, where we looked at some we didn't give the tranexamic acid to, and some we did. We had 1 pulmonary embolus in the entire group, and that was in the group that did not receive tranexamic acid. So we had 0 incidence in the tranexamic acid group. So we're not concerned about that. And it's because tranexamic acid prevents clot dissolution. It doesn't make clots form. It actually is affecting the mechanism of clots dissolving. And it's a different mechanism completely. So we feel quite confident with it.
We don't use it, so that's a great input. We'll probably start doing that. Thank you. Mohit, one question for you. How do you manage a stricture after a sleeve, So what are the options?
Yeah, so the best way to manage a stricture after a sleeve is that first we need to evaluate this patient, and that I think the endoscopy is kind of tricky here, because even if you have a mild twist in the form of a stricture in a sleeve, you can sometimes still negotiate an endoscope. At least most good endoscopists can, and that does not mean at all that the patient is not struggling with that kind of a mild twist or a stricture, which is very common. I usually do a 48 hours barium, and if we have the content retained until then, from 8 hours to 16 hours is something where we could say that you can still call it as equivocal. But then after 16 hours, beyond that, retained barium of more than 30% is something which signifies that stricture is there or a twist is there, which won't be solved even if you are able to pass in an endoscope. In that case, I would go inside and straight away convert it into a Roux-en-Y gastric bypass. We have been very unsuccessful with serial dilations of these sleeve strictures, which I have personally done. The pneumatic dilatations, or even with a balloon. I have used different varieties of balloons to dilate it myself. I learned this from Manuel some 4 years back, and we treated, the patient was good for the initial 2 or 3 weeks, and then again landed up with stricture. So now until unless these COVID times when patients are less inclined to get the surgical procedure done, any patient who would present to me with a problem called as a stricture with nausea, vomiting, not able to tolerate solid food, I would even if there is no stricture, I would consider a twist and follow the same line of treatment as I said.
CK, would you do it differently?
For the stricture management, I think first thing is to do the endoscopic balloon dilatation. If the stricture is could be passed by the endoscope, and sometimes you might try to put a stent if the patient don't want the revisional surgery or fail in the endoscope. For those who have some rotation of the tube, when you see the big curve of the gastric tube, so some stent might works. Then if the medical treatment fail after 3 times try by endoscopic management or stent placement, I think the best way is to convert to Roux-en-Y bypass.
Yeah. So I think this almost everybody agrees on this management. Mohit has given a good tip on barium retention after 16 hours and 48 hours barium, because endoscopically it's difficult to appreciate the kind of twist or kind of stricture, because most of the time it's negotiable, and one wants to look at the positive side always as a surgeon, and want to believe that this will not require a revisional surgery or any intervention. So, Michelle, would you agree with this, or do you want to add anything on the stricture part of?
Well, I think the simple balloon dilatation don't work. You have to use achalasia balloon to really forcefully under several psi, dilate this. We are using the mega stent. You have to use the proper stent. That's another era. People use the wrong stent, and most of the time we can avoid re-intervention with these simple methods. Achalasia balloon, perhaps a second time, and then a stent, and usually that does the trick. It's very rare that we have to do a Roux-en-Y gastric bypass. Now there's another option, and that is the gastroplasty. You can, if the patient wants to stay with their sleeve, you can excise and do an end-to-end anastomosis, or you can open it up and do some sort of a wide plasty closure transversely. So you can save some sleeves if the patient really insists, and if the anatomy at surgery is, you're able to do this without too much problems.
Okay. Dr. Nimeri, one question for you is, and last question from me before Praveen takes over. One of the reasons that people do other procedures is like how Mohit mentioned that, you know, there are different procedures for different type of patients, is the diabetes, the severity of diabetes. That if the diabetes is more severe, you offer a stronger procedure or a procedure like a one anastomosis gastric bypass. Is that, what is the evidence related to that? Is sleeve not good enough for severe diabetes?
I think the best evidence comes from the diabetes surgery guidelines, as well as the studies looking at procedure selection from the Cleveland Clinic, led by Ali Aminian and Phil Shower. And if you look at that, the diabetes surgery guidelines looked at sleeve gastrectomy, gastric bypass, Roux-en-Y, duodenal switch, and gastric banding. And the reason they did not look at one anastomosis gastric bypass is there are no randomized control trials comparing medical and surgical therapy in one anastomosis gastric bypass in the published literature at the time the guidelines were published in 2016. And looking at those four procedures, the best benefit risk ratio is in favor of Roux-en-Y gastric bypass. That's not to say that duodenal switch is not more effective. It is, but it comes at the risks of malnutrition and nutritional deficiencies in favor of Roux-en-Y gastric bypass to duodenal switch. Now, the Cleveland Clinic in their Stampede trial have compared sleeve gastrectomy to Roux-en-Y gastric bypass. And even though the A1C difference is not significant, and even though the study was not designed to show a difference between sleeve and bypass, it was designed to show a difference between medical and surgical therapy, yet at 5 years, Roux-en-Y gastric bypass patients were on lower amount of medications compared to sleeve gastrectomy patients, and they still favor Roux-en-Y gastric bypass. Now, they came out later and looked at their patients and tried to quantify the severity of their patients who are diabetic, and they recommended Roux-en-Y gastric bypass in mild and moderate patients with diabetes and sleeve with severe patients. And I think, in general, a higher risk patient, even if the diabetes is severe, should get a lower risk operation like sleeve gastrectomy.
Praveen?
You want me to take questions or?
Yeah, if there are any questions left, I don't think questions are left. You can conclude. Yeah.
Sure. I think before I conclude, I would want to just throw open I think with regard to GERD is probably, I think I concluded with being the biggest roadblock. I did ask a question to Nimeri earlier during the panel about his thoughts on, is GERD an absolute contraindication for him, and would you do an endoscopy in all your patients? Is there any one of the panelists who doesn't routinely do upper GI endoscopy and also would do a sleeve gastrectomy on early stage or mild GERD? Anyone, any of the panelists who does it?
I think we do routine pre-op endoscopy on everybody, but in terms of, there are some patients, it depends on your definition of mild GERD, whether that's an endoscopic one or a symptomatic one. And we have some patients who use PPIs on a PRN basis, but fairly frequently. If we've demonstrated they've got a hiatal hernia on either a contrast study or an endoscopy preoperatively, then we have offered them the option of a sleeve with a hiatal repair at the same time. I don't know how people feel about that, but that seems to have this is a patient who does not want to bypass, who wants a sleeve, and that seems to have been successful in the patients that we've done anecdotally, but there haven't been huge numbers of those.
Okay. So I think now it's generally been accepted that most surgeons of us have started doing upper GI endoscopies in all our patients, and we try as much as possible not to do a sleeves on our GERD patients. Maybe a few hiatus hernia patients we do. Is there? So I think can I just take it as a conclusion from all the panelists that Roux-en-Y bypass still continues to be the gold standard procedure of choice for existing GERD, or any other viewpoints from anybody else before we close for the evening? Okay.
I think you should frame it, Praveen, that sleeve continues to be golden standard, except in patients who have severe GERD.
Even in this case, I'm going to be controversial to say that if we do Roux-en-Y gastric bypass more and more on severe reflux patients, we're going to see quite a higher incidence of esophageal cancer and problems in these patients. So they will require to have post-op endoscopy surveillance, not only the sleeve, but also the Roux-en-Y gastric bypass. But knowing the Karolinska data that shows that 50% of those patients fail with Roux-en-Y gastric bypass, I am wondering if the operation of NOCA, which is the sleeve Nissen, the Nissen sleeve or the Rossetti Nissen, is much better at stopping reflux than a Roux-en-Y gastric bypass. So this is my question today, that perhaps the Roux-en-Y is not the best operation for reflux in these patients.
I'm sure
I can make a comment, Praveen.
Please.
I mean, I think this is a very controversial comment that's not backed by science, Michelle, and surprising coming from you.
Oh yeah, there is
scientist.
Because there is measurement. There is measurement. If you look at the Rossetti papers, there is measurements of restoration of the sphincter pressure and ablation of the pH. Now, I want to know if there is restoration of the sphincter after Roux-en-Y gastric bypass. Where is the science in that?
I think the reason I say it's not backed up by science is we need to see sleeve gastrectomy for 50 years and one anastomosis gastric bypass for 50 years before we make any comments about cancer. We know cancer does not develop in 10 years. 10 years ago, if I told someone there is a 4% Barrett's with sleeve gastrectomy, I'll be laughed at. But now, 20 years later, after sleeve gastrectomy has come out, we know that. I think time will tell. But today, in 2020, if someone has reflux, they should get Roux-en-Y gastric bypass. When David does a randomized trial comparing his technique to Roux-en-Y gastric bypass and shows it's better, then we can talk about it.
So I think let's not take the debate going. I think we have definitely had 2 hours of interesting session with great inputs from all of you on sleeve gastrectomy. I'm quite sure we had a very interesting topic on sleeve gastrectomy as a gold standard and the roadblock. And I think I'm sure sleeve gastrectomy gold standard is a controversial word, but probably an ideal bariatric procedure for many patients in most hands, if done the right way with a good multidisciplinary management. However, we need to be cautious on choosing it to the right patient. And of course, GERD is going to be a big gray area, and probably something we as surgeons who would do bariatric surgery for the next 20 years, as Dr. Nimeri said, we need to cautiously keep looking for it, maybe work towards methodologies in reducing it, follow-ups to understand, to have sleeve gastrectomy to be there 20 years later, what Roux-en-Y gastric bypass is today. And of course, we had interesting controversial statements from Dr. Michel, but he has seen 25 years of practice, so we definitely value his thoughts. And I think thank you all for participating. We definitely had a wonderful evening. I'm very sure all the participants had a good time having all the great guys out here. Thank you all.
Thank you.
Wish you safe times during this time. Thank you.
Bye.
Dr. Raman Goel.
Thank you.
Thank you. Thank you so much.
Thank
Thanks
you.
for joining.
Bye-bye. Have a nice evening.
You too.
Bye-bye.